So title of the Q&A is what tests should you get? And this is a tough one with long COVID, right? In lots of different ways. Let's start off at the beginning and say that you kind of have to go to your GP and get a full blood set. And most of us on this chat, I'm sure, already have done this, but for people who haven't, I think that's kind of essential because you've got to eliminate anything else that could be causing your symptoms, first of all. A long COVID diagnosis is kind of a diagnosis of exclusion, really. Once you've eliminated everything else that we can test for, then kind of what's left may well be long COVID if you fit the profile and everything else. So the first thing you have to do is see your GP and get your blood work done. Now, don't be surprised if in that blood work, there are some things that are a bit weird. So for me personally, I have had high cholesterol since having long COVID. I have had slightly variable blood sugar, often a little bit higher. I've had monocytes that can sometimes be quite high, eosinophils, which are high. That's linked to MCAS, sort of vaguely, because it's an allergic indicator. Leukocytes have been high sometimes. So don't be surprised if some of that immune blood panel comes back a bit wonky, but nothing is probably going to be way out. It's just going to be a little bit off. And the doctor will say, you're fine. But at least, you've got rid of the possibility that it might be something else, something more acute that needs to be dealt with. So once you've got that first set of blood work out of the way, of the remaining sort of subsets of things that you can test for in long COVID, and the original question that came in here was actually asking and basically saying, we can see all this stuff in research labs, right? We're seeing, people having PET scans for research, people having their mitochondria looked at, people having biopsies in research labs. These aren't tests that are commonly available to you and me on the street suffering with long COVID. So what can you do? And I'm going to break down some of these sort of sub-conditions of long COVID and talk about the tests for them. So I'm going to talk about MCAS, dysautonomia, mitochondrial dysfunction, and abnormal clotting, i.e. microclots. So starting off with MCAS, if you talk to your doctor about MCAS, he'll say, what, mastocytosis? And you'll say, no, MCAS, and they'll go, never heard of it. Go and see an MCAS specialist, and they'll say, oh, by the way, you can get a test for mastocytosis. That's unlikely to be a problem if you're suffering with long COVID. Go and see an MCAS specialist, and they'll say, depending on where you are, some of the specialists in the States at least might have the ability to do some very sophisticated tests, send them off, but it's got to be cold chain, which means the samples have to be sent off and they have to never go above a certain temperature all the time until they get to the very end of this process. And you get negative results back the whole time. You get loads of false negatives. Basically, it is possible to potentially test for MCAS, but it's not a conclusive test. And as I'm going to come back to here, how helpful is that test result once you've got it? And I'm going to address that question again once I've gone through all of them. Dysautonomia, 2 primary tests for dysautonomia. NASA lean test, and both of these are POTS tests really, which is basically where you lean against a wall at a bit of an angle for 10 minutes and measure your heart rate and see if it goes mental. And the other slightly more sophisticated test is the tilt table test, where you lie on a table, it tilts back, flat, and then it tilts up to 60 degrees. Point of it being 60 degrees is that if you're at 100, your muscles are actually working, but at 60, they're not. And so it puts much more autonomic strain on the body to actually manage blood pressure. And they measure your blood pressure and your heart rates whilst you're on this tilt table. Now, this can give a very positive diagnosis for syncope, which is essentially you will pass out after a certain amount of time if that happens, faint, essentially. And that's an indication that you are dysautonomic, / POTSy, that form of dysautonomia. I have had a tilt table test. I failed if you fail or pass, but you know what I mean. I was seconds away from passing out. It was a horrible, horrible experience. Rarely have I felt so terrible as I did on that tilt table. And, the test was over. I got very little breakdown of it. The specialist didn't really talk to me afterwards. It kind of got referred up the chain. Nothing ever happened. But even if something had happened, what might they have done? Well, they might have prescribed me some of the standard POTS drugs, potentially, which you have to make a call about whether you want to take those or not. But by itself, is a tilt table test useful? If someone wants to do a tilt table, should they? I would say probably not, because you will already know if you have issues standing for a long time. You don't need the tilt table to tell you that. And it might well crash you for a period of weeks afterwards. It did for me. So not really recommended. So next on the list, mitochondrial dysfunction. So these are this is referring to some of the research that's looked at people's cells and found damaged mitochondria and the rest of it. These aren't tests that are available to the public. You can't have them. And even if you could, it won't tell you any more than you already knowing if you are spoons limited in your day. If you know that you are spoons limited in your day, we've got a pretty good stab the tail on a donkey kind of probability that there probably is some mitochondrial dysfunction going on there. Microclots, this is another one where there is a test that's available. So you can, through fluorescent microscopy, you can look at the blood and you can see that there are these amyloid deposits, potentially microclots and hyperactivated platelets that can be seen. But the question here with this test, A, it's hard to get, and B, how do you judge the results of that test? Because it's not quantified at the moment. There isn't a number. You don't put your blood into a machine and it spits out a number. If it's higher than 100, great, you need anticoagulants. It's not that simple. You're basically just looking at varied slides of a random cross-section of blood they've got, and they'll look at this bit, and then they'll look at that bit, and they'll look at this bit, and they'll go, there's some stuff there, there's some stuff there. Where do you draw the line? How do you say, well, this is microclotty enough? And then the other problem we've got is the link between actually establishing that these microclots are directly responsible for any given specific symptoms. Yes, we think that they're going to impair vascular function, especially in capillaries. That stands to reason, but have we really directly connected it to symptoms and said, yes, this much microclottage leads to X symptom? No, we haven't. And nor have we got particularly conclusive evidence on the effectiveness of anticoagulants yet. So that sort of brings us through to this thing of, what do any of these tests tell us that will affect what you can do about it? And the answer is not a lot. And that's kind of unfortunate, really. We are left in this awkward, horrible position, which doctors will hate, which is where we're sort of forced to kind of phenotype ourselves and work out what's going wrong with ourselves. And obviously, if you've been into a doctor's surgery and said, this is what's going wrong with me, A, B, C, and D, they will hate you for that. It's their job to do that. But not all doctors are up to speed on the latest in long COVID. So they're not necessarily equipped in all cases to be able to do that. So this treatment landscape is still really, really, really difficult. To sum up the what test should you get question, in a nutshell, go to your GP, get a full set of bloods done, eliminate anything else. If there's some stuff that's wildly out, you might want to consider doing something about it, like, blood sugar, for example, if you need to start going on diabetes medication, or, do you want to go on statins if you've got high cholesterol? Again, that's a separate tricky question. Depends how high the cholesterol is. Yeah, that's another rabbit hole, which will take another 10 minutes to go down. So I won't go down that. But yes, deal with that initial set of bloods. As for all the rest of the long COVID specific stuff, I'm not sure any of it is that useful. So leading into question 2. Let me just pull it up from here. I'm going to pin it at the top of the channel. So you should now see that in the chat. How does one go about deciding which advanced therapies, so that's IVIG, hyperbaric, extended fasting, apheresis, etc., to try? This comes down to a few things for me. You have to do that thing that the doctors will hate, which is phenotyping yourself, working out what you think is going on with you. You have to look at each of the logic and rationale we have and the evidence we have, whatever little evidence we have for each of these therapies. For reference, IVIG is basically an infusion of antibodies. It's used for people. It potentially helps with inflammatory conditions and with autoimmunity. Hyperbaric oxygen therapy, that's where you get into a tank, breathe oxygen under pressure. Extended fasting's what I've just been doing in Germany, which is why I look like a bit of a skeleton. Apheresis, where your whole blood comes out and gets filtered. So hyperbaric in that is less advanced. I don't think that's such a difficult choice to go and do. The risk profile on that is relatively less, and the individual cost of treatment is relatively less than some of the others. But yeah, so you have to look at your own symptom set and you have to think, okay, what do I think might be going on with me? Which treatment do I feel intuitively? And this is a weird thing where you have to kind of listen to your gut, I think, at some level and say, intuitively, does this feel like a good idea to me? do your due diligence, obviously. Look at the risk profile. Look at the place you're going to have that treatment done. Does it seem sensible? Does it seem safe? Do you get a good vibe from the doctors? Can you afford it? Does it stack up enough for you to take a punt? Because unfortunately, at this point in time, pretty much anything you do is a roll of the dice. And you just have to decide which dice you want to roll fundamentally. And that's a really hard decision. When it came to fasting for me, one of the biggest things, once I'd sort of actually properly looked into it and sort of plugged together the rationale, risk profile really low, especially if you do it in a clinical, well, risk profile very low if you do it in a clinical setting. If your general sort of spoon count is very low and you're very dysautonomic, really don't recommend trying it at home. But in principle, do it right. The risk profile is low. But most of all, intuitively, it just felt right to me. And so it's a big undertaking. It's 3 weeks away, 2 to 3 weeks away for me, and costs money. And but I just had a gut feel. And sometimes that's kind of all we've got left to go on. Once you've done all of the due diligence, that's it. And it would be nice if there was some way of quantifying symptoms, plug this into a little equation and then bong, it pops out and says, you need hyperbaric oxygen or you need apheresis. Well, we don't have that. So you just have to, unfortunately, do the research. Boring, but true. Right, next question. Let me just scroll down. I'm going to replace this one. So, new question in the chat. If there's a winner among the things they're testing now, approximately how long before the long COVID and ME world, it's disappeared, has effective treatments? Do you think there is a most promising treatment in the current lot? I don't think it's going to be happening anytime soon, sadly. There are some interesting trials going on at the moment, and I have high hopes for some of them. For example, we all had high hopes for, Berlin Cures and BC007. That came out with a negative results. That treatment is never going to see the light of day. Now, there's all sorts of reasons why that might have happened. It doesn't necessarily mean the treatment doesn't work. It might just be poor trial design or poor phenotyping of the people they put into it to mean that they didn't get the right people for it. And unfortunately, even still, with the trials that are being recruited and started now, my concern is that we still don't understand who to put in them, because we don't have there isn't this magic pill. We're targeting something with each of these trials, right? So someone in a separate question asked about Sipabivart, whatever, the AstraZeneca new monoclonal antibodies. This is Nancy Klimas is running a trial out of UCSF, 100 participants, full RCT. Monoclonal antibodies are very interesting for long COVID. They're one of the most promising lines of treatment in answer to this question for me. But there's a problem there, which is that if we still don't know who we're putting into these trials, we're going to get negative results. If we put a bunch of people who've never had COVID but have got ME into them, well, monoclonal antibodies aren't going to do anything, right? They don't have persistent COVID. I mean, everybody now has had COVID pretty much. So you won't find that many ME people who haven't had it. But you take my point. You have to have the right people who you think are showing some signs. There's some indicator going on in there, whether it's biopsy or a biomarker of some sort, that suggests there's some sort of viral persistence in them. And those people need to go into that trial. Are we at the position yet where we have agreement across the whole medical establishments about what those phenotypes are and what those biomarkers are and how you select these people to understand which targeted treatment we're aiming at what patient group? I don't think that's there. So when are we going to see results? I think that the set of trials that are being put into action now, a lot of which are sadly 3 or 4 year trials, and then it's going to be 2 years before they're published and peer reviewed, and another 2 years before anyone actually filters through to guidelines. There's a good chance that those trials happening now may still be getting negative results because we still haven't cracked the code on the biomarkers to understand who to put into the trials. And that for me is quite frustrating. But going back to the question, what are the most promising treatments? For me, it would be monoclonal antibodies and drugs targeting autoimmunity. Those for me are somewhere up there at the top of the chain, which have a high chance of eliminating symptoms in most people as long as you put the right people in. So, you know, those autoimmunity drugs, if you get the right ones, well, they could very well treat ME people or people with long COVID derived ME that maybe don't still have persistence. For those whose persistence is being driven by some sort of continuous trigger, low level virus, wherever it might be, you know, the monoclonal antibodies. So yeah, that's my take on that one, but don't hold your breath, sadly. Right, let me just find another question. Replace pinned message. The reactivation of stealth pathogens can do a lot of vascular damage. What's your experience with this? Well, this is a hard thing to to say I have experience of this, because I know I did test mildly positive for Borrelia, but I haven't like chopped open my veins to say, oh, my arteries, to say, look, I've got vascular damage. It's a difficult thing to measure. You know, theoretically, pathogens will cause inflammation, they can trigger autoimmunity, and that can cause vascular damage, which can cause the downstream effects of poor oxygenation, hypoxia, mitochondrial damage, anaerobic respiration, boom, 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 right? So we know all of that, but we can't link it all together in a way that's sort of all been put together in one paper that's been put up and everyone's looked at and gone, okay, great. We know that if you have EBV, then this causes X vascular damage, which has this downstream effect. We don't have all of that stuff linked up. We just think that that's what's going on. So a tricky subject that not much we can do about on a patient level for the time being. And the second part of that question was stellate ganglion box, low dose Abilify, dysbiosis, and fecal matter transplants, I think. I'm going to be talking, so if you've noticed on my channel, I've started a series called Everything I've Tried in 5 Years. There's going to be 4 episodes of that, and I've realized I need to have another one on the end, which is everything I haven't tried. So that's going to be talking about these 4 things, potentially. Certainly Abilify and SGB are going to be in that one. And any other common stuff that's been talked about I haven't tried. I'll talk about the science for it, why I haven't tried it, and what I've heard from the people who have, and does this have, you know, possible future value. Right, coming down to the next one. Okay, so I'm afraid there will be some questions here which are outside of my knowledge zone. And this particular question, are CGRPs, monoclonal antibodies for migraines, similar to the MABs that can help long COVID, AGV and Emgality, etc.? The answer to that, I'm afraid, is I don't know. And if I wasn't live currently, I'd be getting my phone out to cheekily ask my Claude AI what the answer is, and then have to double check the answer. So no, the answer is I don't know, I'm sorry. So coming up with the next question here. Any concerns about the risk, or I've just pinned this one. I'll keep pinning these in case you want to see them as well. Any concerns about the risk for dementia with H1 antihistamines? I've avoided pepsin for this reason. Are dementia concerns overblown? So again, right, I only know what I have read on the internet. I'm not a researcher into dementia on long-term use of antihistamines, but my take from what I've read on the internet and from doctors I've spoken to is that by and large, the risk-benefit analysis is heavily in favor of the benefit. Now, there's certain types of antihistamines that have a higher potential chance to cause dementia later. All of it is really low risk, by the way, but even within that low risk, there's the slightly higher risk and the slightly lower risk. So it depends which. I would say if you're going to be taking antihistamines, just check that first. I can't remember exactly what the thing is about the antihistamine that makes it high risk or not, but I can tell you that fexofenadine is low in it, and fexofenadine is very safe, and that's widely accessible. In the UK, you can buy it over the counter. Doctors will give you higher dose if you need it, but of course, you can just take more of the pills you get over the counter. So generally speaking, antihistamines, if they do you good and they improve your symptoms, and especially if they're something like fexofenadine, I really wouldn't worry about it. Having said that, not because of dementia risk, but after being taking solidly antihistamines for 4 years, when I came out fasting, I was able to ditch all of them. And I was quite glad to just not be putting my body constantly through that and have 3 weeks off, and then only slowly start taking them again when I felt like I needed to, when I went back to normal life. So I have, I think taking any medication for a really long period of time, if you don't have to, don't. So with anything like that, if you've got a regimen that's got all of this stuff in it and you've been taking it for ages, it is sometimes worth titrating down on one of them to see if your symptoms come back. And maybe actually you don't need it anymore. So you're not just taking tons of pills for the sake of it. Same with supplements, by the way. I threw all my supplements, well, I didn't throw them in the bin, but I've stopped taking them since my first fast. Haven't reintegrated any of them, bar the ones I take for sleep, like melatonin and magnesium and L-tryptophan. Those are the only ones now I take for sleep. Don't take any in the morning. And my life is so much better without them, honestly. So question here on, might I be able to discuss the Sipabivart trial? Yeah, I kind of did that earlier. Very promising. Unfortunately, going to be a long time before we hear anything about it. It would be nice if we could have like some sort of speed trials rather than going straight into some of these RCTs. If it's possible to do like really quick, small, semi-dirty trials that just, but I guess the risk is if that's negative, does that kibosh the main trial? But sometimes, you know, having spoken to some academics on this, there are ways that this system could be sped up, and it's frustrating sometimes when that doesn't happen. Just coming down to this one here. So thoughts on autoimmune drugs and/or rapamycin. So autoimmune drugs, we haven't got the right ones for long COVID yet. In the end, they might be one of the most effective treatments we get with long COVID. But A, we need to really understand what the autoimmunity is in long COVID and then develop the drugs for that. There's, you know, lots of chat around the GCPR autoantibodies. I don't think we've quite nailed that onto the flag yet, but that seems most promising. But, you know, we have autoimmune drugs to help manage lupus now. I can see a future in which we have similar drugs that might help manage long COVID. They'll probably have horrible side effects. They'll probably only be of partial benefit, but they might improve quality of life. We can always be more optimistic than that, but I kind of prefer to be realistic rather than optimistic sometimes on this stuff. Existing autoimmune drugs that might deal with stuff with long COVID, well, that would be things like the Berlin Cures trial that failed, because that was a drug that was developed for another reason. Can't remember quite what. But yeah, there is the hope would be the fastest way of getting there would be that there's an existing drug that is like, oh, this could work for long COVID. Let's throw it into a trial, which is exactly what's happened with Sipabivart. Well, I can't say it, but those monoclonal antibodies by AstraZeneca, they've already been trialed. They're already safe. They're used for prophylactic for people who have got well, it's not autoimmune conditions. They've got immune conditions that makes them particularly at risk for catching COVID. So they take those monoclonal antibodies to stop them catching COVID, and they've proved to be effective at that. So that's the sort of hope, is that there happens to be a drug out there already that we can repurpose and find it works. Thoughts on, here we go. Thoughts on oxygen therapy, red light therapy. So I don't know if by oxygen therapy you're talking about something different to hyperbaric oxygen therapy. If it is, I can't speak to it without the hyperbaric element. If it's just breathing more oxygen, well, that'll probably help hypoxia a bit, but you're not really solving the problem. Red light therapy. So, okay, so there's another question about, which I'm going to jump onto now. Courtney might drop it into the chat so I can pin it shortly, but it's about, are the mitochondria really damaged? And can we repair them? How do we sort out, let's say, you know, we're going along and half our mitochondria aren't working properly. What the hell do we do about it? So if you Google it, you'll get a few answers. One of those is exercise. That's not on the menu. But there are a few things that potentially are on the menu. Here we go. Here's the question. I'll just pin it in there now. Are the mitochondria really broken? Well, so here's the thing, right? Mitochondria are always being cleared out. They're always being regenerated. That's the brilliant thing of, it's pinned now. That's the brilliant part of the human body. But the thing is, it doesn't, with long COVID, it does on ME/CFS. Potentially that's not happening properly or fast enough. So, you know, when we crash, the idea is that we've used all of the energy that our mitochondria can create, and then suddenly, and our reserves, and then we can't replenish those reserves fast enough because the mitochondria aren't working properly. So how do we get rid of those ones that aren't working properly, replace them with ones that are? My logic with fasting is that the autophagy process during an extended fast, and it's not even logic, there's actually science here, triggers this process of catabolism, where you basically break down all sorts of cells in your body, from fat to muscle to everything. That process of catabolism clears out all of the the junk, basically, the stuff that served its purpose or isn't functioning properly. And it also triggers a process of cell biogenesis and mitochondriogenesis. So the process of fasting, once you get to autophagy, which is 3 days onwards, you are in that process then of forcibly clearing out the junk and forcing your body to create new stuff. Other things that you can do as well, and again, not everybody has access to this, unfortunately. I'm really lucky because whilst I'm here, I do. Sauna and cold water immersion. So again, subject to tolerance. If you can get into a sauna for as long as you can tolerate and build up over time, because tolerance does improve, and this will also help your autonomic control too, then go for the cold water immersion afterwards. Both of these things, and especially together, will do a process called hormesis. And if you just Google hormesis, it's spelt H. In fact, let me write it into the chat for you. Hormesis. So Google that. And this process of hormesis is said to basically, well, I'm going to read it out because I copied a definition earlier. It's a phenomenon where a small amount of a stressor, like a toxin or environmental factor, can actually be beneficial, leading to an adaptive response in an organism. These beneficial effects can include enhanced resilience, growth, or improved health at lower doses of stressors that would be harmful at higher doses. Now, so that's kind of the basic biological principle of it. But going into saunas, cold water immersion, and notionally red light therapy can all help the body basically force itself to regenerate and make new mitochondria. So not everybody has access to a sauna. Not everybody has access to cold water that's the right kind of cold water. I'm lucky here. I've been able to do that along with my fasting. But there are a few things that we can do, but it's not like you can't take a pill like, oh, I'm going to have the pill that makes me have more mitochondria. Equally, NAD plus via IV, NAD plus via oral routes doesn't really do anything either. So that's not a very useful route. But basically, don't worry. It's not like your mitochondria are knackered forever. We just have to find a way to get the body into a place where it can actually clear out the junk and remake the new stuff, because that's fundamental. If you're still alive, your body has the capacity to regenerate, right? So it's not the end of the world. There is hope. Right, so here's another question about PEM. Can you talk about the two types of PEM? I was experiencing one type, but really recently I seem to be experiencing both types. Now, when I'm talking about the two types of PEM, this is a differentiation between essentially dysautonomic response to activity and the spoons crash that happens when you've spent too many spoons. And the difference between these two is that the dysautonomic response to activity will typically happen during and after that activity in the follow, so it'll happen, well, for me, it happens within 10 seconds of starting the activity, but other people, it might start half an hour later. But fundamentally, that happens shortly after the activity, if we're talking about PEM, by its nature being post-exertional. And then the spoons type, the MECFS type, happens a day later. So what's happening with the dysautonomic type? Fundamentally, you have asked your body to do something that it can't handle the autonomic demands of. So the blood pressure requirements of standing up and jumping on a trampoline, right? That's challenging for the body. Standing up in a shower with hot water coming onto you and standing up, that the body has to suddenly deal with the heat, it has to deal with standing up, has to deal with bending over and standing up again. That's autonomically challenging. So people might feel bad after they've had a bath. They might feel bad after they've had a shower because there's an autonomic stressor there, and the body is left in a position afterwards where it can't reset itself. It can't control itself back again. So you'll find you have things like frequently shortness of breath, chest pain, headaches, dizziness, tachycardia, palpitations, tunnel vision if it gets really bad. Those are, you can just Google dysautonomic symptoms and it's basically all of those. You may also have digestive issues potentially after that as well, because the autonomic system controls digestion. So those are the sorts of things that can happen shortly after exercise. The PEM you get the day later is very individual. This is what we all call a crash, right? And everybody's crash is a little bit different. It is possible to, what I ought to say in terms of PEM related, two types of PEM related exercise, is that there are some types of exercise or activity that will cause one PEM and not the other. So I'm pretty sure that if I started jumping up and down on the spot now, squat jumps, and I did, 20 of them, I'd probably get dysautonomic pretty fast. But if I only did 20 of them, and then my rest of my day wasn't too stressful, I probably wouldn't get the spoons crash, the MECFS crash the next day. However, I could have a really sort of day where I'm just always doing things all day and I never trip over that autonomic capacity limit that my body can't deal with. I could just be walking around all day, be on my feet all day, lots of Zoom calls, lots of phone calls, I don't know, 4 of these things, and I'd be wrecked the next day. I'd crash the next day. So that's a spoons crash. So different types of activity might incur different types of crash. Now, obviously, if you do a lot of something intensely, if I went and did a HIIT workout, I'd get both. But this, again, is very individual, which you get, what you can tolerate, what you can't tolerate, and learning your body and your tolerances and being able to preempt when you're getting close to the limits of either of those is really important. And that's where sometimes, if you're relatively new to long COVID, a wearable, so something like a Whoop, or even better, the visible device, can be really good at helping you learn the signs before you've detected them yourself about when you're doing too much. So I recommend that. Another question here about crashes. Can people still get crashes after over 5 years? Yes. Even after periods of time with no crashes? Yes. This is happening to me and is very bewildering and discouraging. Yeah, for sure. It's you can get crashes after any amount of time. Speak to anyone who's had ME/CFS for 20 years. They can still crash, right? Just time doesn't make it go away. If you still have the condition, you can still crash if you do too much. As for the relapsing, remitting nature of the condition, normally that comes in a slightly shorter wave cycle than that. So you might have a good week or two and then a bad week or two. That's the most common kind of relapsing, remitting, or maybe good month, bad month. But some people have good 6 months and then terrible 6 months, or good 6 months and then bang, suddenly they'll crash. And that's quite normal too. Again, there probably was a stressor of some sort that brought on that crash. But what people who recover often say is that those gaps between the crashes get longer and longer until eventually they don't happen at all. So if you've had a long period of time with no crashes and you've just crashed, well, that's fine. Hopefully, the next period of time will be even longer before you crash again. And after that, longer again. And eventually, there won't be any crashes anymore. So that's the way I would look at that. I would take the optimistic one on that. I have a question here on for sauna, cold water, red light to help with macrophage. How long does that take? You know what? I'd be Googling that to see if there is any science on, like, you need to do this for X amount of time. The general advice that I have seen is that you ought to be doing sort of the sauna, cold water at least 2 or 3 times a week. Daily is always going to be better. But again, you have to factor in the energy cost of going to do it. And if the energy cost of going to do the thing is too much, then you're not going to get the benefit from it. Because if you're crashing yourself from just trying to do the therapy, this is the same with anything. Hyperbaric was the same for me. The energy cost of me getting to the chamber and getting back again was only just less than the benefit of the chamber. So you've got to be like, what do you do there? So, if you are doing it 2 or 3 times a week, or if you are doing it every day, how long of that will it take to see the benefit? It's going to be so individual, isn't it? Now, what I would say is that I adjusted to the sauna here pretty quickly in terms of my autonomic control. So I was getting in at first, and I'd be in there. And this is the relatively cooler sauna. So it's about 80 degrees normally, 75, 80 degrees. I'd be on the bottom row, and I could tolerate about 7 minutes, and then I'd start to be feeling really funky. I wouldn't have got a sweat on yet, but I'd be feeling unwell, and I'd be like, it's time for me to go. And after a week, I was able to stay 12 minutes, and I was getting a bit of a sweat on. After now, I've been here for 2.5 weeks. I was on the top row. It was 88 degrees, and I was in there for 15 minutes, and I had a sweat on from 7 minutes, and I sweated all the way up to 15, proper, like I used to be able to, and I got out and had my cold dip. So I don't know whether I can say that that's related to what the benefits that might have been on a mitochondrial level, but certainly in terms of autonomic control, your body can improve quite quickly. And my hope would be that having done that will make me a lot more heat tolerant this summer, because I've previously found summers really hard with long COVID in terms of my heat tolerance. So I'm hoping that has conditioned me a little bit to actually improve some of that autonomic control. I'm going to come back to that. Have I tried hydrogen tablets mixed in with water? Did it help? No, unfortunately, I haven't tried it, so I can't comment. But the follow-up to the question I was just answering is this. Might sauna provoke syncope in people with POTS? Yes, it might. I think you have to be very careful about this. And I think if you know that you are heavily dysautonomic or POTSy, you should you just speak to your doctor. Because fundamentally, when you're going into a sauna, your blood vessels are dilating, right? And if you've got POTS, that's bad. The last place you want to be having syncope is in a sauna, especially if there's no one else in there with you. So yeah, if you're POTSy and if you know that you have blood pooling issues or any of that stuff, speak to your doctor. Be very, very careful about it. For me, I know I'm not that POTSy. I'm more heat intolerant actually than I am POTSy. Whatever it is, like your heart rate's supposed to go up by 10 beats a minute when you stand up normally. POTS is above 30. Mine probably goes up like 16 or something. So it's not quite right, but I'm tolerant enough of the sauna, but I still had to adjust slowly, and in a sauna that wasn't as hot as a standard 90-degree one. This is a good question. Question about PEM terminology. Is PEM the right terminology for people with dysautonomia? MECFS people might say no. But if you look at the broad definition of the term, as opposed to what we sometimes take it to mean, if you say PEM, most people will take it to mean the one that happens the next day or the day after that, the 24 to 48 hours later. But technically, if you're having post-exertional malaise or post-exertional symptom exacerbation, the term itself doesn't include after 24 hours. So there's no reason why if it happens 30 seconds after activity, it couldn't apply to that too. But you're right in pointing out that typically when we hear the term, we think of it being the 24 hours plus version. And I would normally, given a straight bat, I would call the dysautonomic type, I would just call that dysautonomic symptoms post-exertion. I would probably be a bit clearer if possible like that. But I think when you hear the PEM word used, it could be either, probably the 24s, but yeah, depends who's saying it, because this is one of the things, right? It's also that thing of how do you define PEM? How do you define long COVID? Like this is still a lot of muddiness around all of this. And there's going to be for a while, I think. Follow-up question here. Did the sauna get easier for me whilst fasting? Yes, it did, but I don't know if the fasting helped. Arguably, it could do because your body temperature drops whilst you're fasting, and my general autonomic control has massively improved whilst I'm fasting. So that would suggest that saunaing whilst I'm fasting would be easier. But I haven't had a control test of being able to go into the sauna over a 2-week period without fasting to be able to say it was easier when I did or not. But arguably, yes, the fasting might have helped. Although, I mean, the cold water immersion is technically harder when you're fasting because your body temperature is lower and it's harder to warm up again afterwards. But if I don't, yeah, that's a fair point actually, because I would have struggled to get into the cold water before the sauna, whereas normally I would have been able to, but it was too cold before the sauna. So I have to have the sauna to be able to go into the cold water. So yeah, the fasting probably did help the sauna, probably impedes the cold water immersion. But if you do the sauna first, the cold water immersion is fine. Another question here. And for reference, I've probably got about 3 or 4 minutes left before my brain explodes. So if you've got any more questions, throw them in. I hope you've all managed to cope with me just rabbiting constantly for 40 minutes. Bloody hell. For heat intolerance beyond water and salt electrolytes and compression clothes. Yeah, that's it. That is it. Again, the hormesis effect, but when it comes to adapting the nervous system, so small amounts of exposure, which you can tolerate, and then removing yourself from that environment. So to sort of reprogram and autonomically, you can tell I'm going, aren't you? Autonomically condition the body to that will help. But fundamentally, that is it. Be very hydrated. Make sure you've got plenty of salt and electrolytes and the compression clothes. Again, the compression clothes don't help with the heat, do they? Not everybody. The funny thing about dysautonomic stuff is that, you've got these sort of like a column chart, right? Where you might have one column which is super high in POTS, another column is quite high in, like medium high, let's say, in heat tolerance. Another column is like at the bottom for digestive dysautonomic stuff. So there's all sorts of different ways that the dysautonomia can, and another one might be activity tolerance, right? So different people are going to have different column heights on this chart. And so there probably is a correlation between being broadly more dysautonomic and broadly less dysautonomic, but you can be quite POTSy and heat tolerant and vice versa. yeah, again, it's really complex. And we don't have like a little device you can plug in that says, boom, here are your scores, 62 heat tolerance, like, you know, like your FIFA cards or something. Don't have that, sadly. Got another question here. Hi, Jez. In a previous video, you talked to Dr. Klaus Wirth. He's mentioned being open to crowdsource funding for MDC-002. Have you considered using my platform for something like that? Yeah, so relatively early in the pandemic, I thought really hard actually about trying to crowdsource a project that was basically going to be like a centralized funding thing, where we put together a board of patient advocates and we raise a load of money and we try to identify how to spread this money around on the most promising treatments, targeted stuff that's chosen and developed, sort of chosen by the patients in accordance with academics who's interested, is to find the stuff that we feel is most pressing, because often the research gets done is just a special interest of an academic. It's not necessarily what the space needs at any one given point in time. But in doing my research on that, I brainstormed it and really sort of war gamed it. So what happens when you go out and you do this? And it's a huge job and it's a huge responsibility, and there's a huge amount of accountability that comes with it. And fundamentally, it was going to be my only job for a year or two. Would it have ever got anywhere? It would have really hung me out on the hook in a way that exposes you quite a lot to lots of attacks for taking money from ill people and all the rest of it. And fundamentally, I just didn't feel comfortable asking people for money. I mean, obviously, if you're watching this, you've all, you know, given YouTube 99p. So I have asked you for some money, but that's the kind of level that I sort of felt finally after 5 years, 99p is just about okay. But asking for any more than that on that sort of level, yeah, it was too big a thing. There is a world in which the right people might be able to do something crowdfunding like that, but I just couldn't face that at that time and still probably can't now, unfortunately. But good question. Okay, I've got one more question after this one. Have I tried, this one's going to be a short one. Have I tried oxaloacetate supplement for fatigue? I have not, I'm sorry. If anyone has one more question before my brain turns into pure cheese, then fire it in. By the way, at the end of this, I'm not going to go away immediately. I'm just going to go quiet and I'm just going to read through this comments. And if there's anything I can just quickly point out, because all I've been responding to, just to keep the flow on this, is are the questions that Courtney's dropping in for me to just pick out. But I'll go through and read the comments properly after. This is a good one. Great. I'll finish with this. How do you feel about the viral reservoir theory of LC? It seems science is pointing towards this. I think so too. But not everyone. That's the thing. And I think this is what's going to scupper research in this area, is that I don't think it's the case for everyone. We know that ME/CFS can exist in the absence of the pathogen. It's an initial infection that sets off a cascade in the body. Now, I'm going to put random numbers on this. I'm going to say that half of people with long COVID would fit an ME/CFS diagnosis. I don't know, maybe it's 25%, maybe it's 75%. I'm just going to say half. Of that half, how many of them have got persistent virus? We don't know. You could argue the other half have got the really weird symptoms, the tinnitus, still got the loss of smell and taste, all the really wacky stuff that doesn't fit into, I'm not being pejorative by saying wacky, it's just there's some unusual stuff in there, right? You could argue that group are going to be more likely to have the viral persistence on the grounds that we know that ME/CFS can exist without it. But I would also wager that plenty of that ME/CFS group, plenty of that 50% do have it. Now, let's take me, for example. I have had a form of ME/CFS before, post-viral fatigue syndrome, when I was 21. Pretty sure that was post-EBV, although I didn't have a test for that at the time. I got better after a year, as you probably all know, because I always end up talking about this. But I haven't got better after a year this time. So why the difference? Age, maybe? I don't think so, though. My feeling is there's still something there ticking this over. Now, is it viral persistence? somewhere, wherever that might be, and we have found it everywhere. There's a really good study recently. Oh, I'd have to bring up my notes, but the really good study recently that looked at, was it macaques? No, it wasn't macaques. It was some sort of primates, and it found that the virus was everywhere in these. Basically, I think they just killed them and cut them up, and they found that the virus was everywhere in them after 3 months after infection. We've had plenty of other human biopsies done, plenty of other human autopsies done where we've found the virus all over the place. So it's really not an outrageous thing to suggest that the virus is still kicking around in some of us. The question is finding it. The question is getting rid of it. The question is, can you make yourself... We also think there's some of that persistent virus in people who don't have long COVID. So if you can't get rid of it, how do you make your body behave like someone who doesn't have long COVID, even if it's still in there? And that's kind of, I'm trying to do that sort of control alt delete on my body by fasting to see if that's one way of achieving that. And time will tell on that front. So yeah, my money is that if I had to put a bet on viral persistence being a thing in at least 40% of people with long COVID, I'd put quite a lot of money on that. And probably diminishing amounts of money up to sort of 80, 90%. I think it probably isn't that many, but I think could easily be half. It could easily be half. What day is this in my fasting? Very quick question. This is day 19, and I finished on 17. So I broke with an apple and a soup on Saturday, and I've now had 2 full days of refeeding. So I'm still building up calories, still very easily digestible stuff, sort of cooked vegetables, and no heavy grains, no heavy bread or anything like that. So I've got to be very careful with sugar and stuff for the time being. It's going to be a week of slowly building back up again before I can go back to normal food. One thing I've learned this time is I'm taking 2 extra days at the end of the fast to refeed, because I think I rushed it too much going back to normal life. The journey back is stressful. There's a lot that you go straight back into at home, and I crashed fairly quickly afterwards. I was really good, and then I crashed. And so this time I'm just going a bit more gently. And I think that's a much more sensible way to do it. Thank you very much for joining me today and this Shakespearean soliloquy of hopefully some use. So thank you very much. I'm going to stay on the line here for a couple of minutes and just go through the comments. So I'm going to be quiet and be weird whilst I scroll through them. But yeah, thanks for joining. It's been a huge pleasure.